Wonderful. I thought, and it's a privilege to be here with you all, with my colleagues from Jordan, and I thought if you had 4 talks, you didn't want 4 talks on ptosis, and it's about time to undo some of the good work from the 3 previous talks, and to tell you what we do in the opposite situation when a patient presents with lid retraction. Now, this arguably is a subject that's not covered that often, but of course poses a greater risk to the cornea than ptosis per se. Now, I'm not going to spend the whole of the next 15 minutes or so talking about thyroid eye disease, but if you look at a book and you look at the reasons for lid retraction, 90+% is going to be thyroid eye disease. And this is true, but there's a significant other numbers and reasons for lid retraction. And I'm going to show you 1 or 2 interesting cases during this talk. So yes, we've got thyroid eye disease, which can present with primary or secondary retraction, but we should also remember the other causes. These include congenital, facial nerve palsy, a very often overlooked cause of lid retraction, all causes of cicatricial posterior lamellar disease, such as ocular cicatricial pemphigoid. Trachoma, of course, is the biggest cause worldwide. And then orbital inflammatory lesions can lead to lid retraction, iatrogenic lesions, and also certain cicatrizing or sclerosing secondary metastatic conditions in the orbit in the Levator complex. But most of you, of course, like me, are familiar with thyroid eye disease. So here's a few examples of lid retraction in thyroid eye disease. Now, this first patient has primary upper lid retraction. And it's quite important when you have a patient with upper lid retraction, that is to say, the lid margin at or above the upper limbus, to decide whether it's primary or secondary. Now, this patient that you see in front of you has primary lid retraction. She's looking straight at me, and she has lid retraction. And she has lid retraction when she looks down, and it's hard to tell when she looks up. But she also has this typical lateral flare, as you can probably see here, particularly on this picture. And if there's one pathology that goes with lateral flare, it's going to be thyroid eye disease. So if you have a patient and you think it looks like thyroid eye disease, but the blood tests are normal, etc., but they have lateral flare, as you can see here, you can bet your bottom dollar that it's going to turn out to be thyroid eye disease. So that's primary upper lid retraction. But here we have another case of primary upper lid retraction. This is a patient I had who presented with this pretty impressive upper limbal show. Here you see scleral show. We would call this 1 millimeter of scleral show. Now, she has primary upper lid retraction, normal thyroid function tests. Now, unfortunately, thyroid eye disease does not have a label, and there is no one blood test that will confirm it. But when you've got somebody with upper lid retraction and you have no other cause for it, bear in mind that it will probably turn out to be thyroid eye disease if you wait long enough. Now, I also wanted to show you a particular phenomenon. Lid retraction is a static condition, but there's another condition which is related called phase lag. That is to say, the lag in phase between up gaze and between down gaze. And I'm going to show you, if I can, this patient who, when she looks up, you see she has lid retraction, she has thyroid eye disease, but she has a stiff levator complex. So what happens when she looks down? What happens when she looks down, if I can show you, is this. Look at those upper eyelids. Look at those upper eyelids, and you see how slow they are to come down. We'll do it again. She's looking up. Yes, she's got upper lid retraction. And when she starts to look down, watch how the lag of the lids follows. It's delayed. That's called phase lag. And that's a sign that's not often reported. It's not often discussed. It's not often written down. But so when I look at a patient, I think, where is the lid? Is it static? Is it retracted? Number 1, yes, it is. Fine. Number 2, is it primary or secondary? Number 3, is there phase lag? Because if there's phase lag, they're also going to have a lot of problems when they're blinking, because they'll have an incomplete blink reflex. And that's why they get a dry, sore eye. Now, here's the other case, which is secondary upper lid retraction. Now, here's a gentleman. He's looking a little bit down. He's not particularly retracted, but here he is. The moment he starts to look into the primary, so he's looking at you and me in the camera, and look at those lids. Ping, they go right up. And the reason they go right up is why? Well, you all know, of course, is because the inferior rectus is stiff from the retraction and from fibrosis. So when the patient tries to move the globe up, they have difficulty. So what does Hering's law do? Hering's law tells the globes to look up, but at the same time, it tells the eyelids to look up. So you get the secondary upper lid retraction. So if you did a CT scan of this gentleman, almost certainly you'd find evidence for active or past inferior rectus involvement. So I think I have a picture of him or another one. Again, this is secondary upper lid retraction. So here he is, he's looking straight at us. It's quite a sight, isn't it? And look at those lids being retracted. Okay, so he's looking down. It's pretty good when he's looking down. He's not that retracted. The moment he looks up, let's do it again. The moment he goes up, ping, those lids goes up. Why? Because he's having difficulty looking up. And so he's recruiting his levator complex as hard as he can at the same time as recruiting his superior rectus to attain the primary position. So that's thyroid eye disease, but there are other causes for lid retraction. And the reason that facial nerve palsy is so often overlooked, and I'm sure you know the answer to this, but I can't ask you for real, the reason is that they often have brow ptosis at the same time. So a patient comes to you, and the general practitioner refers the patient to you. Dear doctor, please see this patient. They had a facial nerve palsy, and they now have ptosis. Well, the one thing you don't get really with a facial nerve palsy is ptosis. What they mean is they have brow ptosis, and when men have a heavy eyebrow, it looks like ptosis, but when you lift the brow, you'll find retraction. Now, this is a particularly bad case. The worst cases tend to be iatrogenic after surgery. For acoustic neuroma, for example, Bell's palsy tends to get better, and if it doesn't, you have to ask the question, is that the diagnosis? But here's another patient, and I'm showing you this because you would imagine that every patient with severe lid retraction will always have corneal exposure. And it is true that they have corneal exposure if it's iatrogenic, or they lack corneal sensation, or they lack a Bell's phenomenon. So here you see the Bell's phenomenon. Now, the patient at the top has a great Bell's phenomenon. The lady at the bottom has a congenital facial nerve palsy with upper lid retraction. Here she is trying to close her lids. You heard about that animal, Lagos, not able to close the eyelids. This lady cannot close her lids, but because she has a good Bell's phenomenon, she's protecting the cornea. So if you want to know the answer to the question, what is the prognosis for my patient, and they have a poor Bell's phenomenon, maybe they have poor corneal sensation, then you know the prognosis is probably fairly poor. So I'm going to show you another case of lid retraction. This one is also secondary. And this was an interesting lady who had frontal sinus disease, and she had a fistula that was discharging through the bone, through the superior orbit, into the upper lid. And she presented like this, and she was treated with the lubrication drops for a long time before somebody asked why it was that she couldn't close her lid, because she had this tethering up to the frontal area, up to the arcus. And she was tethered due to this chronic discharge, and she couldn't close her eye at all, but I would imagine she had a very good Bell's phenomenon, because here we see a patient with a white eye. So here you see her trying to look down, not terribly successfully because of the loss of skin and the cicatricial changes in the anterior lamella. Here you see that side view all tucked up in here. And so the answer for her, we had to create some anterior lamella. Look at the good side. That's a lot of anterior lamella. It might well be 25 to 35 millimeters. On this side, it's barely 10 or 11 or so. So whilst this is not a talk about reconstruction, one of the options we chose, first of all, is to put some Dermis fat graft, which we did, onto the rim here to block any further cicatricial change. So if you're faced with a patient with recurrent cicatricial changes, Dermis fat graft is a very good spacer. It stops the tissues from sticking together again. What else did we do? Well, we needed some anterior lamella. So what we did is we did a pedicle flap, and we brought up a pedicle flap as far as we could here, and I think we even put a skin graft in here, and she wasn't quite closing the eye, but she was a lot better than when we started. So that was an unusual cause for lid retraction. Now here's a lady I'm treating at the moment, except I'm not really treating her because it's COVID, and she came to me just before the lockdown, about 3 weeks before the lockdown, and she said, Mr. Varity, my right upper lid has definitely become retracted. It happened over a matter of a few days. And I said, are you sure you don't have a ptosis on the other side? And she said, no, that's been always like that, but my right upper lid's retracted. And she had a little bit of tethering. So I thought, well, this is rather unusual. Why would you get spontaneous lid retraction no lateral flare, thyroid function tests normal, no history of thyroid at all, entirely painless, no diplopia. So I did the scan, and here you see the scan below. And if you look at the levator complex here, you can make out that there's some thickened tissue in the levator complex. Hard to know whether it's just the levator or a bit of superior rectus, but I think it's mostly the levator. You can see it here. Look at the other side, and you can actually see there's not that much going on there. Now, I was due to biopsy her. I think it was about March the 10th or so, but because she's been relatively stable, we were going to try and get her in as an emergency, but time moved on and she decided she didn't want to come to hospital, not unreasonable. And here we are later in mid-May, and she's still stable, still pain-free. And I suspect, and I'll maybe tell you the answer when I get it, that she's got an idiopathic inflammation that's causing this cicatricial process here. She's stable. She's not had breast carcinoma. She's had no other history, and she doesn't want yet to come to hospital. And it reminded me of a patient that I had many years ago who had a similar story. I'll show you his picture next, if I can. Try and get to his next picture. Here's his picture. And you can see this gentleman also, he presented with a sort of painless fullness and a little bit of lid retraction and some swelling in the anterior levator. And I took him to a biopsy, and it showed idiopathic orbital inflammation. So yes, usually it presents with discomfort and pain, but it doesn't always. So just bear that in mind when you see a patient with strange lid signs and a CT scan that shows a diffuse mass. Here's my lady, and you can start to see a little bit of the similarities. And I saw this lady, did the scan, I thought, I've seen this before. I've seen it years ago in a previous patient. Now, just one or two other examples. Here we have a congenital upper lid retraction. It's very rare, but it clearly does need some fairly urgent treatment, although, of course, in children they have a fairly well lubricated cornea and a good Bell's phenomenon. Don't ever be fooled by pseudo-retraction. It is there waiting for you and me, pseudo-retraction. Look at this lady. Now, normally, she fixates with her right eye. And when she fixates with her right eye, her left eyelid looks higher. And the reason is not that she has a ptosis on the right or she has lid retraction on the left. You know the answer, don't you? The reason is that she has a left hypertropia. She has a vertical imbalance between the two eyes. So if she fixates with the left eye, then she'll look like she has a ptosis on the other side. So she could either have a pseudo-retraction or she could have a pseudotosis, depending on which eye she's fixating with. So don't be caught out by that. Do your cover test, your cover-on-cover test, because it will catch you out periodically. And as you've just heard from the previous speaker, don't forget, if you've got a patient with a good old-fashioned aponeurosis, dehiscentosis, like you see here, what happens? You get a ptotic lid, Herring's law, and lid retraction on the other side. All right? So don't forget that retraction might just be a reflection of Herring's law that is trying to keep the lids up, and nothing more than that. Now, here's a particularly special case. I hope you're still all with me. Kasim, can you hear me?
Yes, David, thank you very much. You're all good.
Am I good?
Perfect.
Yes, no, that's good. I'm just checking you can hear me.
Perfect.
So that's wonderful. Now, here's a really interesting case. Patients with trabeculectomies. We've all had problems with them, haven't we? This lady has lid retraction on the left. Here's her bleb, as you can see it here. Here's a PI on the other side. And these patients are really difficult to get right because they're unpredictable. When you lower the lid, you find that it can go back again, and nobody knows really the reason for lid retraction, although I suspect it's cicatricial changes in the back of the lid, in a posterior lamella cicatrization. I think that's what's happening in this patient. Here you see her again with this diffuse trabeculectomy bleb. Never had any bleb problems, but she presented with lid retraction, and I've seen quite a lot of patients like that. And the one thing I will say to you is warn the patient of the difficult prognosis with lid lowering. You can lower the lid and you're too low, or you can lower the lid and you think you're too low and it goes back again. So be very careful with these patients. They're quite difficult to get right. But here she is, and she did well, and she had an anterior lid approach lowering. So I'm going to just go on some of the slides and pictures of how we actually do it. But the key thing, like you heard from one of our other speakers today, is ptosis or lid retraction is just a description. It's not telling you what's going on. You could have a cicatricial process in the orbit like breast carcinoma that I've seen in a lady who had surgery after surgery till the penny dropped. But her problem was not that she had idiopathic lid retraction, she had something else going on. So you have to get the diagnosis. So what's your choice of operation? Well, If it's just a small retraction, you can release the Mullers muscle, but otherwise, generally I do an anterior approach. And I'll just take you through that. So here you see a Mullers muscle resection, and we open up the conjunctiva at the top of the tarsus, and we open up the conjunctiva, and we just slip off the Mullers. And here you see the Mullers here. It's just been taken off the conjunctiva. You'll be careful not to damage the aponeurosis, which is here. That's white collagen, of course. And here's the Mullers muscle here. And you just slip that off, and you don't even need to stitch it closed. But what about patients who have this serious lid retraction? This patient's got 4 or 5 millimeters above the limbus. She definitely needs more than a posterior approach Muller release, as you can see. And so what we do with these is we do a graded response. You've heard of the Corneve lid retraction technique, the Corneve approach, where you do a full thickness blepharotomy. Now, most of us do not do that. We do a graded approach, the end of which is a full thickness blepharotomy. So here's a lady, we do a lid skin crease opening, and we identify the tarsus here, and then we're going to start to take the aponeurosis off the tarsus. All right, so what have we got here? First of all, I'm going to open the septum. And the reason that we open the septum when we want to lower a lid is that if you're not careful, the lid will come down, but the skin crease will be pulled up. And there's one thing that patients don't like this patient. She's a thyroid patient, she'd had the decompression, got a little bit of a divot in the lateral part, and her lid came down beautifully, lovely level, but not happy with that skin crease. Possibly because I had not opened the septum fully, or possibly because I had, and she needed Dermis fat graft, and she did very well. So do open the septum to allow the levator to go all the way up. So here you see me taking off the levator. Here are the scissors. Here's the levator muscle, and here's the tarsus. So I'm taking it off the tarsus from left to right completely. Okay, here's the edge of the levator. You can see it here. And very often, because of their lateral flare, what do we have to do? We have to divide the lateral horn. So here's the diathermy, and we've got it either side of the lateral horn of the levator. We diathermy it first, and we cut across it. That is highly effective and often does need to be done. Not so much the medial horn, don't go there, but the lateral horn will often need quite a bit of attention. So here now we have a muscle and a levator. I've cut the lateral. I might well have cut a little bit of the medial, but I think chiefly the lateral on this side. And I'm going to let this off, and then I'm going to let it off with the Mullers. All right. So here you see that the anterior aponeurosis, I've got it here, is completely free of the septum, so it can slide back. It's like a piece of cheese in a sandwich. It's going to have to slide all the way back without pulling anything with it. And so here you see, here's the conjunctiva, here's the top of the tarsus, here's the conjunctiva, and the Mullers is now on the back of the apo because I've taken my dissection and I've stayed hard on the tarsus, hard on the conjunctiva here, the big beefy vessels, and the Mullers has come off with the apo. And I do this empirically, and I go up and up for 5 to 7 millimeters, constantly checking the height on the table. And if you haven't got enough, okay, then you can open the conjunctiva. But here's the secret. Don't open the whole conjunctiva at once, because what you're going to get is a flat lid contour. Doesn't look good. Go for the lateral part first, and you open it right out to the orbital rim. Here's the orbital rim, and I'm opening it all the way out. And then if you need to, open it medially. But the big secret is, and I'm sure you all know this, so maybe it's no secret, is to leave this bridge of conjunctiva. Because if you don't, yeah, you get a great lowered lid, but you get a flat lid, and it doesn't look good at all. Whereas if you leave a small bridge in the middle here, then you can actually grade it, and you do it step by step. So like 90% of the work is probably in the last 10% of the operation to get that level just right, and it's not easy. So that's the central bridge. And if you want to, you can take it narrow and narrow, or you can do one cut here and the other cut slightly higher up to lengthen it by degrees and take it slowly. Take it really slowly, because if you don't, all of a sudden you look at the patient and you've overdone it and they're ptotic. All right, so here's the flat contour you want to avoid. This guy's not bad. He could be better, but she could be a lot better. Okay, she's had decompression. She could probably have had more decompression. Look at those flat lids. It is not appealing. All right. Now, here's the secret. If you do open the conjunctiva, and if you only close the skin, one thing can happen that you don't want. You get a patient who complains of a watery eye afterwards. They don't really have a watery eye. They have a hole because you did not close the orbicularis separately. So if you open the conjunctiva, great. But if you open the conj, close the orbicularis in layers, and then close the skin. Otherwise, occasionally, you'll get this annoying complication. And here's another one you can see on this slide. I've almost finished. We're getting there. I hope you're still with us. And here you see a patient who had the worst of both worlds, a flat lid and a watery eye, and the watery eye was due to the fistula. Look, it's not that difficult to treat, but it's better not to get it in the first place. What do? Well, of course, a fistula means you've got skin epithelium joining up with conjunctival epithelium. So you've got to open that all up, strip out the epithelium from the hole, and close it in layers again. Not that difficult. And here's a patient who had exactly the surgery that I showed you. Here she is to begin with. And she did require opening of the conjunctiva. But I would say in most cases, I don't need to open the conjunctiva, but I do if they like 5 to 7 millimeters above the limbus, as you see here. But I don't do it straight away. I let off the retractors, I have a look, and if it's not enough, then I start to open the conjunctiva. Here's a last story. This lady, thyroid eye disease, lid retraction, had been treated with botulinum toxin injections to try to get the lid coming down. Well, you and I can see that Botox is no way going to let this lid come down. She'd even had a medial tarsorrhaphy elsewhere. What this poor lady needed with a doctor was a proper anterior approach, lid lowering, which she duly had, and then having had it, she then needed the other side done. So even if the patient might even be active and they're immunosuppressed, you can still lower the lid. She wasn't active, but even if they are active, you can lower the lid to protect the cornea, and that's important. So last slide to remind us. Thyroid eye disease is the #1 cause. Of course it is. Think primary retraction, think secondary retraction, think is there phase lag. Congenital, you're not going to see too often. Facial nerve palsy often slips through because they have a brow ptosis. Anything causing cicatrization of the back of the lamella, OCP, cicatricial pemphigoid, and pemphigoid are the two main culprits there. Orbital inflammatory lesions, and do think cicatrizing processes in the orbit, and of course iatrogenic, such as apriclonidine, which can be used for somebody who's got a ptosis due to botulinum toxin, for example. You can actually help the lid go up a bit further if you need to with drugs. And of course, that's also the case with adrenaline, as Kasim so nicely showed you earlier on. So thank you very, very much for your attention. That's all from me, and I am going to unshare my screen, and I hope you found that interesting.
Thank you, David. Fantastic, honestly, as always.
You're muted,
Thank you very much. Can you hear me?
Yes, we can hear you well, Dr.
Perfect. I just wanted to see if anyone has any question. I saw Dr. Omar Gawagze had a question earlier on the chat, and Luay, they were asking about the link to YouTube. Can you provide us with the link that we're going to put on the YouTube, please?
Dr.
Yes, later, yeah, we can do it.
Okay, can you just put it in the chat box, please, if you don't mind, Luay, so that people can get it? Or I'm not sure how do they usually get it at the end of the
later,
meeting?
Dr. Qasim. Yeah, later maybe. Yeah.
Okay, no problem. Thank you very much. Go ahead, Dr. Omar.
Good evening, everyone. I have a couple of questions. I will start with Mr. David, if you don't mind. You can hear me well, right?
Yes, I can hear you. Good.
Yeah. I was talking about, you were talking about the lowering the lid. I want to ask about specific case with the facial nerve pulse. Usually we use the gold weight. Can we try like to lower?
Yeah. Okay.
For the molar muscle? Yeah.
Well, yes, actually, I don't use a gold weight primarily because, to my mind, there are two muscles that are working together. One closes the lid, one lifts the lid. And the problem is the muscle that closes the lid. So you want to weaken the muscle that lifts the lid. So for my facial nerve palsies, I would normally recess the retractors before putting a gold weight on. Personally, I think that it is better for them. And if they still have retraction or failure of closure at nighttime, I might consider a gold weight, but I wouldn't go for a gold weight straight away. I've had lots of great results just by recessing the retractors to begin with. It's straightforward and simple, and it works very well.
Okay, thank you so much. So you'll start with the recession, then you will go after a while for a gold weight, or will you never go for a gold weight?
Well, you never say never in medicine, do you? And I've got some great colleagues who use a lot of gold weights and platinum chains. But I have to say, in all the patients that I treated with facial palsy, which, as you can imagine, is quite a few, I'd say I have one with most of them with a lid retraction, recession of the retractors, and it's worked just fine.
Okay, thank you so much. Thank you.
Thank you, Dr. Omar. We have a question from Dr. Samer Kharmak. Go ahead, please, Dr. Samer.
Good evening, everybody. I hope you can hear me.
تفضل حبيب.
I would like just to make a comment that this was an extremely beautiful and outstanding session. I would like to thank you personally, every single speaker, Dr. Varity, Dr. Sam, Dr. Thabit, and the beautiful organizer, Dr. Qasim. We learned a lot tonight, in fact. Thank you for your, your effort. Thank you so much.
حبيبنا Dr. Samir, thank you very much for joining us. Thank you.
Pleasure.
Thank you.
Pleasure.
Dr. David, Mr. David, there's a question for you from Dr. Ahmed Shafi. How to avoid ptosis and blepharotomy and conjunctival incision?
Well, you probably just have to learn the hard way, I'm afraid, because you do get surprises. I remember one lady that she had retraction, and I lowered her. She had a 7mm retraction. I lowered her. She was a delightful woman. Came back to clinic the next week, a complete ptosis, and on the table she looked good. The trouble is when they're lying down, you're not sitting them up, so you don't have gravity. So the trouble is that when they're lying down, you take away gravity, and they may just look okay, and you throw in 1 Newton of gravity, and down they come. And that's why that critical last 5% takes so long to get it just right. It's very easy to overdo it. So I slow down when I'm within 1 millimeter of where I want to be, but it can still happen, and it is unpredictable. Lid retraction is unpredictable in its outcome, particularly in glaucoma patients. So how to avoid it? Well, you could be conservative, but then of course they need further surgery. But I think chiefly I would suggest do not open the conjunctiva entirely. That's what Corneve described, which you will get flat lids, and you'll get very swollen lids because the lymphatic drainage is slow, and you will also get ptotic lids. And then you've got to go back and repair them, which is interesting quite often because the levator is not where you think you left it. It comes back down again partially, which is curious. So I'm afraid there is no easy solution, but just slow down when you're getting to within the last millimeter.
Thank you, David. We have another question from Professor Assam. Do you have a comment?
Yes, please. I actually have 2 comments. I agree with Dr. David that do not do blepharotomy, no matter what the book says. If you really worked on thyroid patients, do not do the complete blepharotomy. Just go millimeter by millimeter, graded recession, Levator and Muller, whether anterior or posterior approach, it probably will not differ in our hands, but do not do the complete blepharotomy. The complications and the results are usually worse, probably even than the lid retraction. That's my first comment. The second comment is on the frontalis sling. When we do frontalis sling on congenital patients, we have to understand that it is a temporary procedure, no matter what you use, apart from fascia lata. Don't think it really matters. Is it silicone? Is it Gore-Tex? Is it the Proline? We have to understand that the patient will grow taller. The implant will not grow. So all frontalis sling procedures with artificial material are temporary because of this, and they will all cheese wire as long as the kid is still growing. That's why many of us now, and there's a lot of talk in the recent literature about the frontalis flap, using the frontalis itself as a sling material. We've done this, and many people presented it, but always remember that sling in a kid is temporary because the kid will grow, the sling will never grow.
Thank you, Professor Assam. Thank you very much. One more question from Dr. Zaid Al-Abbadi to Dr. Thabit, please. Go ahead, Dr. Zaid.
Good evening. Thank you all and for the nice webinar. Thank you, Qasim, for organizing this. My question goes to Dr. Thabit about using the silicone rod in frontalis sling. Is it essential to fixate to tarsus to get a better results, especially in bilateral cases? I mean, for better symmetry.
Thank you, Dr. Zaid, for this question. As a matter of fact, I used to fix it when you fix it. So I stopped using this. It's not a must to fixate to the tarsus, as a matter of fact. So it's not. I'm not doing it anymore nowadays. As Dr. Assam said, it's a temporary procedure. At the end of the day, the patients will need, so it goes, it will outgrow the silicone rod, and he will end something to grow with him as he. So I'm not fixing it to the tarsus unless I do open approach technique.
Yes, thank you.
I hope I answered you. You're welcome. Thank you.
Thank you, Dr. Thabit. We just have one last question from Dr. Omar Gawagzik. Go ahead, please.
So again, I have a lot of questions, but I want to ask Dr. Thabit about the sling when there is a poor levator function. Did he ever tried, like when it's like too, especially in the young kids, when you are trying to evaluate your kids, it's like poor levator, but it's not good enough. 3-2. Usually, I tried like to do a levator resection before going to the sling, and I think it's a less complication. And what about this?
Dr.
Thabit.
I couldn't get your question properly.
Okay.
I think you mean that if you could to go straight forward to the anterior levator section for ling. You mean that?
Yeah. For the congenital ptosis,
yes.
Did you ever tried like to do a levator section, maximum resection before going to the sling?
Well, the problem with the maximum resection, there will be more lid retraction, especially in down gaze. So, what I prefer to do in congenital ptosis with very young children, a temporary procedure until is
I think
old enough to do proper assessment. So I'm not using it anymore.
Okay. So you go just directly to the sling, then you evaluate. Okay. Another question, Dr. Thabit. Hello? Dr. Thabit, can you hear me?
Yes, please, I hear you.
Okay. About the slippage or the breakdown of the sling.
Yes, Dr. Yes, I can.
Okay. If you get a slippage or if you get a breakdown for the sling, you just go and do another one, or you need to take it out the sling.
Or breakdown what?
The breakdown of the sling, breakdown or a slippage of the sling. If you're gonna do a redo surgery, you have to go to take it out, or you just insert another one.
Yes. If you want to do redo what?
Redo after a slippage or a breakdown of the sling. Do I have to go to take it out? The
breakdown, and you are doing. Well,
I think Dr. Thabit has a problem in the voice again.
If you use the silicone rod, it's not.
Dr. Qasim, can you rephrase the question, and if you can redirect the question to?
I hear. Hello.
Yes, Dr. Thabit, please. Dr. Qasim, if you can redirect the question to other speakers, if you can comment on Dr. Omar's question.
Would that accept silicone rod or not?
I think, Dr. Omar, we can ask Dr. Thabit, but let's work on the connection. I'm just looking at, there's a couple of questions for David as well. David, there's a question from Rawan that I missed, sorry, earlier. She wanted to ask you do you have recurrence post this technique of levator recession? Do you get retraction of the eyelid post levator recession again? Does it recur?
The simple answer to that question is yes, it does recur. Does it recur every time? Clearly it doesn't, but it does occur in a substantial minority of patients. And I think that it will recur if you have an active process. It certainly will recur in the context of upper lid entropion. I didn't really talk about that, but upper lid entropion due to ocular cicatricial pemphigoid is associated with a significant retractor element with lash ptosis. I know that's not quite the question, but those are the ones that do recur of anything. And so if you're ever correcting an upper lid entropion, if you don't recess the retractors, all you're doing is just everting the lashes, but you still got a retracted lid, and they're the ones that recur. But the thyroid ones can recur as well. If they're active, they can recur, or if you haven't done enough. And your window for not doing enough and doing too much comes with experience, and it's a tight window.
And then there's a question from my good friend Roman. If you discuss upper lid blepharotomy, how do you prevent against the boxed appearance of the upper lid and raising of the crease?
Well, I showed the pictures of the upper lid blepharotomy, but when I reflect on my patient base, I'd say the great majority, I don't open the conjunctiva at all. I just keep recessing the retractors till I've got what I need. I mean, and this works for me. It works well. However, it is a good question, and he probably didn't get the particular slide that we were pointing to. You leave a central bridge of conjunctiva, Roman. That's what you do. So you can open up the conjunctiva laterally, and you say, okay, lateral flare's better, still a bit retracted. Open up the conjunctiva medially a bit, and then you leave a central bit of conjunctiva, and you can taper it like that. You work out the system for yourself, of course, but you can taper it. But I think you're right. If you open up the conjunctiva the whole way, you certainly get lid lowering, but you get a flat lid and you get a swollen lid too.
Great, thank you. Just to finish off, Dr. Thabit, can you answer Dr. Omar's question? Is the connection any better?
Yeah, so sling or not. Is that hello? Can you hear me?
No, listen,
can you hear me?
I think the internet connection is pretty weak. Sorry.
Dr. Thabit, if you can type your answer in the chat, maybe this can work.
And at the very end, I want to thank you all. Thank you, Dr. David. Thank you, Dr. Assam. Thank you, Dr. Thabit. It's been a really nice webinar, I hope, and I thank you for all the colleagues for joining in from oculoplastics to other subspecialties. I hope it was beneficial to everyone, and inshallah, hope after the COVID-19 we get to see each other in a meeting sometime soon. But again, thank you very much for accepting the invitation, and thank you, Novartis and the Jordanian Ophthalmological Society.
And thank you, Kasim, for putting it together.
Thank you very much. Thanks,
Thank
David.
you very much, Dr. Kasim.
Thank
you
you
for the speakers.
Everybody take care. Nice to see you all.
Thank you.
All right. Thanks.
Thank
then.
you. Bye-bye.
Everybody, thank you.